Hi everybody, I'm Reda Ibrahim at the Montreal Heart Institute. I'm working in room 2 here. I have the privilege to work with Ahmad Ayek, which is a fellow from Lyon in France. My colleague, Dr. Raymond Cartier, cardiac surgeon here at the Montreal Heart Institute, and the entire the team. The anesthetist with us, it's Dr. Christian Ayoub. So today we have an interesting case to present. Can we have the slide, please? Um, It's going to be a structural case. It's going to be a TAVI, but using direct LV pacing and constant hemodynamic guidance. Next slide, please. So this is a brief history. This is a 81 years old maid who present with progressive shortness of breath since few months. Previous history of a bicuspid aortic valve, ascending aorta replacement. It was in 2003. Bioprosthetic aortic valve replacement using a Carpentier-Edwards Magna-Ease number 27. It was in 2014. Hypertension, diabetes, dyslipidemia, permanent AFib, and two cancer, but in remission at this point. Next slide, please. So this is his medication. He's anticoagulated and other classical drug for cardiac patient. Next slide, please. This is a baseline ECG. As you see, is in AFib, but no significant conduction disturbance. Next slide. Transthoracic echo last time was performed in March, revealing a dysfunctional aortic valve. Aortic valve area was 0.8, mean gradient 37, borderline LV function, but still not too bad. Mild to moderate pulmonary hypertension with severe TR. We performed also an CAT just 2 weeks ago. Borderline cardiac output, but maintained mild pulmonary hypertension. PA pressure was 37 on 12, mean was 20/23, and non-significant coronary artery disease. Next slide. This is his scan. So we have good femoral access, not too tortuous, big vessel, not too diseased. Next slide. Large aortic sinus, VTC was fine for a valve-in-valve procedure that we are planning to do with a core valve. You have here the simulation of the core valve, 29 millimeter valve, leaving in theory enough space to perfuse well the coronary arteries. Next slide. So procedural consideration in this case, how we should treat him. He was operated two times in the past for cardiac surgery. I think at this point we will go for transcatheter procedure. He's on the table for transfemoral TAVI. In terms of transcatheter procedure, should we do only TAVI, or should we combine with another kind of procedure? We will stay focused here on the TAVI. Which valve for valve-in-valve? I think we have good option here. Typically in this center, we like to use a core valve for valve-in-valve procedure, leaving bigger area. Should we use LV or RV pacing? Today we are going to use LV pacing with a special guide wire you will see. And should we consider to break or frac the surgical valve? As you remember, he has a 27 millimeter surgical valve, which should be fine enough, but it's always possible to frac the valve in place because it's possible in this case. It's a Magna-Ease valve. And then we can potentially eventually discuss the medical treatment after valve-in-valve, but keep in mind that this patient will remain anticoagulated because he's on AFib, but we can potentially debate should we give maybe a medication that we can potentially reverse, like the dabigatran in the first 3 months of the procedure, and should we add an antiplatelet agent after valve-in-valve procedure? Next slide. So this is the plan for today. We have already vessel access here. We have access on both sides, right and left femoral artery. We did that under echo guidance. We have a Cook 14 French introducer in place in the right femoral artery, a 6 French in the left. We just gave heparin. We're going to use for this procedure a TAVI wire, which is a new wire designed to deliver a valve, but also to provide hemodynamic guidance and to rapid pace. We are going to use an Evolute FX 29 millimeter valve, and then we will close with closure device, the manta on the right side and the angioseal on the left side. Everything is fine. Next slide. So this is the valve that we are going to use. It's an Evolute FX that we will try to align well within the surgical valve. Next slide. This is the app, valve in valve app, showing that the true ID of the surgical valve in place. Remember, it's a Magna Ease number 27. The true ID is 26, 25, I think, or 26. And so it's why we are going to use a core valve 29. And this is in accordance with the chart providing by Medtronic also, showing that in the Maya East 27, we can put a core valve 29. Next slide. This is the wire that we are going to use today. It's the OpSense TAVI wire designed for structural procedure, similar to the Safari guide wire that we are using since a long time for TAVI. So pre-shaped guide wire. It's that wire. It's the leverage of their technology that we are using for evaluate coronary stenosis. The opto wire to do FFR or DPR in the coronary artery. But this is the hemodynamic guidance part of this wires is included now is a structural guide wire. Next slide. So this is the wire. So it's a typical TAVI wire like the Safari, but with two unique advantage. You can pace with this wire directly, even if the wire is not covered with a catheter, because the wire is insulate. So you can pace directly with the wire using an Alligator clamp. We will show you that during the case. And the wire is providing also hemodynamic guidance because there's a distal sensor in the ventricle. It's a fabric optic sensor providing direct and constant pressure during the case. So we will have that all the time during the procedure. Next slide. So this is the setup and the display that you will appreciate during the procedure. We will have the aortic pressure coming from the pigtail, the pressure in the ventricle coming from the guide wire. We will have the aortic pressure, systolic, diastolic, mean. We will have the LV pressure, the systolic, but also the end diastolic pressure, and the gradient. It's possible to have the mean, the peak, and the peak-to-peak gradient, but we are going to focus today on the mean gradient. We will also have the aortic regurgitation index. Next slide. Giving an idea of the amount of aortic regurgitation. As you maybe know, the aortic regurgitation index is the difference between the end diastolic pressure in the aorta and the pressure in the ventricle. And if the value is low, let's say below 25, typically it's because it's related with significant AR. Next slide. So during the procedure, having the OpSense guide wire in place, we will have hemodynamic guidance. So at baselines, we will have the gradient. After potential predilation, it's not the plan here. During the deployment of the valve, after valve release, after potential post-dilation, if we decide to post-dilate or to break the surgical valve, and at the end of the procedure. In terms of pacing, we will rapid pace on this wire to deliver the valve, but we will have the wire in place also available for backup pacing in case the patient is end up with the complete AV block. And as I said, you can pace with this wire even if it's not covered with a catheter because it's fully insulated. Next slide. Okay, that's the end for this. Let's start. We have femoral access. As I said, we have a 6 French sheet on the right femoral. Can we show that, the groin, please? Can we show the groin here? Okay, here, so we have a 6 French short sheet in the left femoral artery. At this point, we have a 14 French Cook sheet on the right femoral artery. We can show you the angiogram. This is the angiogram on the right side. We are clearly in the common femoral artery, ready to go for the procedure. So let's go maybe for the, Flow check. You want to do flow check now? No, maybe. Yeah. Okay. La valve est prête. Parfait. Okay. So we will start from now. Do the angiogram. Try to cross the surgical valve. Il y a des docteur Cartier. Allez-y avec lui peut-être. Ouais. So you see the surgical valve in place. As I said, it's a Magnaise number 27. In this case, the ascending aorta was also replaced before the surgical valve. I think the valve is well aligned. Okay, on va juste le placer ici. Okay, ready to go for an injection? Okay, go. Oh, this one. Okay. So large sinus, we should not be too concerned by potential coronary obstruction. Okay, let's try to cross the aortic valve. Unfortunately, there's a lot of catheter that they are back order, including AL1 catheter that we are using all the time for hein? Ça c'est pour traverser la valve. So there's a lot of back order, and the AL1 that we are using typically to cross aortic valve is not available at this point. So we are going to use a GR4 at the beginning with a straight guide wire. So Matt is coming with the GR. I think we are going on the right direction now. What's the catheter? Okay. Does it get stiff? On va prendre le guide régulier. Okay, this is the stiff guide wire. We'll take the softer guide wire. When they are replacing the ascending aorta, Dr. Cartier, where they end up, they are typically at the ST junction. Okay, now with the regular wire is going easily. Let's use the straight guide wire now to cross. So sometimes it's challenging to go across a surgical valve. Let's see what would happen here. If it's not going well, we will potentially change the view. Sometimes when we go RAO, we see better where we need to go. I will just remove a bit the pigtail just to be sure that it's not in your way. Because we have good landmark, the surgical valve in place. Ah, cool. Well, almost. Patient is not under general anesthesia, just mild sedation. Is very calm at this point. We we are big fans since sometimes now of the minimalist approach for TAVI, meaning no general anesthesia, no echo guidance, no central catheter, and LV pacing that we will demonstrate using the TAVI wire. That's going. We need to be sure that we're crossing in the valve. You don't want to end up in a paravalvular leak, for example. So let's measure quickly maybe the pressure. We cannot measure the pressure now here. We will measure the pressure in the LV directly with the TAVI wire that we will introduce in the ventricle. I want to show you maybe that wire. Um, do you see that? Can we show the wire here? Okay, cool. Yeah, this is the TAVI wire. It's coming packed like this. This is the connector here that I will remove. It's that I can connect and disconnect that anytime during the procedure to have the pressure. So this is the wire here. It's the X small guide wire. We have also the small option. X small is a loop of 3 centimeter in the apex of the ventricle. And the sensor providing the pressure is at the end of the wire, but at the junction with the insulation, the orange part on the guide wire. So this is the sensor here. So I need to pull back on this wire, flush the wire within the loader. We'll do that now. So I will remove the wire until I reach the junction with the sensor. So we will flush that like this. And then after flushing, I will introduce the wire directly in the ventricle to be able eventually to obtain the LV pressure. So this is flushed now. We'll introduce it directly in the ventricle. I'm flushing, so wet to wet connection. And then you can advance slowly. I will let you go, maybe with the wire. Of course, we need to be careful. We don't want to end up in the mitral valve. We want a nice loop in the apex. It's a stiffer wire. It's a stiff wire. It's stiffer than the Safari, but less stiff than the Lunderquist, which is an advantage for valve-in-valve procedure, for example, also or aortic, horizontal aorta, because we want a nice support to deliver the valve. So Dr. Cartier will introduce slowly the loop. I think it's trapped somewhere. I think we should probably go back with the catheter inside. No, I think we are trapped somewhere. Can you go back? Okay, cool. All right, cool. So as I said, we want to be free in the ventricle. At this point, we have the wire in place. I can remove the catheter and we will connect to the distal end to have the LV pressure. So at this point, we will, connect with the opto monitor. We will have the pressure in the LV directly. So again, remember that the LV pressure is coming from the wire. The aortic pressure is coming from the pigtail in the aorta. We can potentially push back the pigtail on the valve, Ahmad, please, to be closer. Yeah. Okay, now we have the gradient. So as I said, so can we change its peak to peak? We have the aortic pressure, systolic, diastolic, the mean aortic pressure. We have the ventricular pressure, and you have the mean pressure across the bioprosthetic surgical valve. It's 24, roughly 20, maybe roughly 25 to 30, and the ARI is not low. I will flush well the aortic pressure. Ah, no, okay, I think we are. I will flush the aortic pressure just to be sure that the system is well flushed. We can potentially do the zero also of the aorta. If the zero is good, so we should have a reliable gradient here. So I flush well my aortic pressure. So there's no leakage based on the aortic registration index. Mean gradient is roughly 25 to 30. And we are ready to go. Okay, let's do maybe the fluoro check. Again, I can disconnect the pressure like this. We will be able to recuperate that anytime during the procedure. The valve is already low. We will do the fluoro check. Do you want to do an angiogram, guys, or? Well, we did it, huh? We did it. Yeah, we did it. All right. We'll let you go with this. Donc, Dr. Cartier and Dr. Hayek will deliver the valve. So we need to check that the valve is well loaded. We'll turn clock. We want to appreciate the distal fold of the valve within the catheter. It's maybe 2 lines, which is absolutely acceptable. Yeah. So we want less than 4, so we are definitely perfect. So we will remove the short Fort French introducer in the groin to introduce the valve on the TAVI wire. Yeah. En haut? Okay. Okay. So it's the Evolute FX system. With the spine allowing us to do a very controlled deployment of the valve. Si jamais ça bloque, Dr. Cartier, vous nous le dites. OK. So as I said, the TAVI wire is a stiffer wire than the Safari, which is a true advantage for valve and valve procedure, for example. So let's try to do commissural alignment. Yeah, so I think it should be fine. There's a marker at the that is looking outside the aorta now on the right side. Turn. Before to cross, I guess we can potentially test the pacing. So I want to show you maybe the setup for LV pacing. As I said in my slide, we have Alligator clamp. It's going to be a unipolar pacing. So we have one clamp here in the groin, in the skin actually. There's a needle, and connected to the needle, there's one alligator clamp, and the other one, the black one, the cathode, no, is going to be connected directly on the wire. There's a specific place that is denuded on the guide wire to place the alligator clamp, but you can actually put that clamp anywhere. It's working, but it's better to put that in that specific area. So we can potentially test the pacing. Christian. Parfait. It's pacing well. Typically, output for the pacing is 25, which is the maximal pacing because we are pacing from the outside. It's pacing well, so we will maintain that beautiful pacing just to minimize the amount of extra beats. And now we will slide slowly the valve in, the surgical valve. If it's not going well, we can pull gently in the wire just to be sure that we are more central. It's going slowly. I think it's almost there. Huh? Okay, cool. I think we are in place. Can potentially push a bit more wire in the ventricle. Have a better position for the pacing. And we can potentially start to deploy here. Hein? OK. On va changer de chat, peut-être. On va prendre le chat de 22. C'est mieux ou pas mieux? Comme ça, peut-être, c'est un peu mieux. Peut-être on est un peu mieux aligné. Parfait. I think I'm trying to align well the surgical valve. I think it's the case now. So we can start to deploy here, maybe, Ahmad. So it's slow pacing for now. We'll just flare the distal part of the valve. I can push on the guide wire to, yeah. Just now that the valve is too low, push on the guide wire, yeah. And Dr. Katsi is pulling the same time. We will flare gently. Let's say, yeah, let's flare a bit more. Okay, let's say here, okay, like this. So let's put the valve a bit higher now. Okay, okay. And at this point, we can potentially go with the rapid pacing, maybe to touch the other side. Are we still a bit low, maybe? Maybe a bit higher. Okay, like this, I think. Okay, fait que c'est un rapid pacing. Let's go rapid pace, maybe 180 beats per minute, just to touch the other side quickly. And now go fast. We want to deploy in place as fast as possible. OK, go more 80. OK, on peut commencer à baisser un peu le pace. Parfait. And now see, you can appreciate the rapid pacing on the LV, the LV pressure. You can also see constantly the aortic pressure. We see that there's a residual gradient. The valve is maybe 80% open, the core valve. We need to figure out if we are too high or fine. I think we are a bit high, maybe. No? I think the valve is under deploy. I would suggest at this point probably to recapture and try to go a bit lower because there's a risk that we need to post dilate here. So let's do this. We can maintain the pacing like this, recapture. Can do that, man? Maybe let's recapture and let's try maybe to redeploy more lower. So again, you have always push maybe Dr. Garcia down if you can. Maybe more lower maybe. Can you? Okay, recapture un peu plus. We will recapture a bit more. Now we can, okay, now we are definitely down. Let's go low higher. The valve is at least pre-dilate now. Okay, I would suggest to open here. OK, parfait. Puis ici, on pourrait aller, maybe a bit higher. Yeah, a bit higher. Okay, now, okay, rapid pace again, Christian, s'il vous plaît. Rapid pace, we will redeploy again here on the rapid pacing. It looks better, it looks better. Okay, it will open at 80%. Okay, relâche un peu. We will slowly release the pace until we'll reach 100, yeah, 100 beats per minute again. Valve, I think I prefer this position. It's more open. There's a residual gradient that we can appreciate with the TAVI wire, but the valve is not fully open. At this point, if we are happy with the position, we can release and evaluate immediately after the procedure, the residual gradient. I think we're not bad here. I don't know what you think, but I think we can potentially consider to deliver the valve here. Okay, so I can pull on this wire gently just to remove some tension, maintaining my pacing, but the pacing it's optional here. And I would potentially deploy, yeah? You agree, guys? Yeah. Go slowly, Ahmad. Maybe Dr. Kerti will push some point, but gently. Go slowly, slow. There's no rush. Go, okay, slow. Okay, now the two paddle are released. Okay, off scopy, Dr. Kerti. Now we have the wire in place, but we will see, you see immediately what's going on with the gradient. Remember that we still have the delivery catheter in place. On va prendre le champ 32, s'il vous plaît. On peut arrêter le pace, s'il vous plaît. Now we will pull on the guide wire just to be sure that the nose cone of the delivery system is centralized. Now we will pull gently. We don't want to Parfait. Don't want to remove the core valve. And now we can remove the delivery system. We'll put the short 14 French in place in the groin and evaluate the gradient to see if we need to pose dilate this. But again, having the TAVI wire in place, we don't need to do any exchange. We will have directly the LV pressure. And if we need to pose dilate, we are going to be ready to go directly on the guide wire. So fourth French short sheet back in the right femoral artery. Are you using EPC? So we have a question from the audience here. In which case are you using echo guidance? We are not using echo guidance. I think having the TAVI is the advantage. Typically, if we use echo guidance, it's to measure the gradient and to measure the aortic elucidation. Two things that we can evaluate well with the TAVI wire. So there's no need for echo having this wire in place. There's no distal protection device in this case. This is something that we are used rarely now, in very, very specific case only. What appear to be the chance of needing a pacemaker here, I think it's quite low. I mean, when we put the valve inside a surgical valve, the risk to end up with a permanent pacemaker is low. And there was no conduction disturbance at the beginning. Eh? Yeah. Does absence reduce procedural time? Yes, we think that it's decreasing the procedural time because there's no exchange. So if you put this wire, there's no need to pull back the wire to put the pictate to measure the LV pressure. So yeah, definitely we will save time and radiation exposure. So as we increase the safety also with this wire. Yeah. Please expand on your experience with the options. It's quite new, huh? We did first in man with the TAVI wire. We did the limited market release on the first 60 patient in Canada, but the experience with this wire is still limited, but it's expanding. Are you planning to balloon dilate first? No, we did the direct valve implantation, but we will evaluate at this point now if we need to post dilate. The plan for valve often is to put the valve in place and to decide if we need to post dilate after. So let's evaluate well now the gradient post valve in valve. I want to, at this point, what we want to do is to equalize to be sure that we have good pressure. So we will pull back the TAVI wire from the ventricle to the aorta. Remember that with the core valve, the leaflet are supraannular. So we are in the aorta with the sensor. Stay here, Dr. Cartier. We will, let me flush maybe also the pigtail in the aorta. So now we will equalize the pressure. We have a pressure in the aorta. We have also the wire pull back. We will equalize that like we do for FFR. And then Dr. Cartier, you can go back in the left ventricle. And now we should be able to evaluate well the gradient. So here there's a residual gradient, roughly 14. There's no much leakage because the aortic regurgitation index, the area is above 25, but there's potentially a higher gradient that we like. Typically for valve in valve, especially with a large surgical valve like this, we want to have like maybe value below 10, maybe millimeter mercury. So we should probably consider to post dilate here. I like the position of the valve also, so I think we have a safe position for post dilation. Donc, I think we should post dilate maybe a 25 millimeter balloon, maybe. Do we have that 25 millimeter balloon in place? I think at this point, there's no need to break the valve. If you break the valve, you can use a non-compliant balloon. Typically, it's going to be a 28 millimeter balloon, Atlas Gold or True balloon. But I think just a post dilation at this point will be helpful. So again, because we have the TAVI wire, there's no exchange to do. We will go directly in the TAVI wire and we will reevaluate the gradient after the post dilation, still using the same wire. 25 millimeter balloon, nucleus. Okay, nucleus 25, it's good. So it's going to be a nucleus 25 millimeter balloon, 4 centimeter long, I think. So critical thing for post dilation, we need a good rapid pacing that we will still doing on the LV pace guide wire. So using this wire, you replace typically for center using RV pacing, you're replacing the introducer in the femoral vein, you're replacing your RV pacing catheter. You maximize your safety that point, but also you save some time because there's no need to insert temporary pacemaker in the RV. So I just disconnect the connector from the end of the wire. We will go directly again on the wire. So there's 3 markers on this balloon. again, we will put the alligator clamp on the guide wire. Donc ici, on va faire, we will pulse dilate Christian here, okay? It's going to be maybe 180 beats per minute again for pulse dilation. Are you going to inflate, Ahmad? Or? Okay. So rapid pacing on. Yeah, balloon up. Uh, pacing off. Balloon off. Yeah, pacing off. Yeah. Just slide. We don't want to go too high with the balloon because we don't want to damage the leaflet, but I think we should be a bit higher. Let's go. Okay, like this. Okay, rapid pacing on. Balloon up. Balloon down. Pacing off. I like now the pulse dilation. I think the valve is a bit higher, but it's definitely better. The deployment is better. Let's remove the balloon carefully, Yaman, maybe. Okay, and now we can leave the balloon in place if we want. Evaluate the gradient directly with the wire. But let's see oui, mais regardez, on va juste regarder le gradient. Let's reevaluate the gradient now. See, the gradient is much better. So mean gradient is almost 0. Wow. Okay, let's remove completely the balloon. I think we will remove the balloon completely, probably do an angiogram, and I think it's going to be the N. I mean, we have like a beautiful final gradient here. Pourquoi? Okay, parfait. Okay, let's reconnect the wire. I will flush well again. The pigtail should be fine. So let's see. See the mean gradient now, it's 2, 3. Yeah, Ari is definitely high. No, there's no leakage. So it's a beautiful result post dilation. I think there's more question coming from the audience. Would echo not assist here now? I think echo is not helpful in this case like this because we have the TAVI wire. I think if you don't have a TAVI wire, you will either put the pigtail, measure the gradient with the pigtail, but use echo to measure the amount of AR. But again, having the TAVI wire in place, we don't need echo in this case at all. We have all the information that we need, no gradient, no much AR based at least on the aortic registration index. We will finalize maybe with an angiogram. Let's remove the wire. We can always just pull on the wire, but it's a bit safer to remove the wire in the ventricle with a catheter. C'est correct. Okay, let's remove the TAVI. Parfait, maybe a final angiogram here. Ok, on est prêt pour l'injection. Le quartier, maybe push the pictic a bit. Yeah, low. Copy. Okay, yeah. Good. Okay, let's do the angiogram. Injection. So the position of the valve is perfect. It's fully expanded in the surgical valve. There's no AR and there's no compromise of the coronary perfusion. I think it's a perfect result here. So we need to close the access. Any more question or just the thing that we need to discuss that you? Yeah, I think a patient was operated twice in the past. Yeah. So can you show me maybe the screen in front of us? I think I can show you maybe the display coming from the opto monitor and the opto the TAVI wire. Um, Stiff wire, is here? Stiff. Okay. So can we potentially show the screen that we have in front of us before we see we show what we do in the groin? Maybe the front screen. Yeah. So top left, you see the display coming from the opto monitor. So we have the baseline gradient, 28 millimeter mercury pre and post gradient 2 after the post dilation. You can appreciate also the end diastolic pressure of the ventricle, 12 at the beginning, 10 after, so very stable. No aortic agitation at the beginning because the ARI is above 40. Same thing at the end, so no AR before, no AR after. So it's just perfect. Okay. All right. So now we will now come with the mammary catheter to do the crossover. This is something that we like to do all the time here. Okay, we need to recuperate the catheter here. Yeah. We are planning to close here with the Manta 18 French. So plug to close large access. Okay. So we will come from the left femoral artery to the right. This is the mammary catheter going on the right side. Pousse un peu. Pousse, pousse, pousse. Ça, c'est-tu guestif encore ou non? Régulier. Pousse un peu ton cathéter. On a peut-être. Ou un glide, peut-être? Ouais. Let's take a glide maybe to go negotiate more easily. If it's not going easily, I will put a glide, take a glide. C'est correct, on peut le prendre. OK. Ah, ouais. Hein? Okay, here, no, ici on va faire un ACT. We need to do an ACT and potentially give protamine before the Manta. Parfait. ACT is 221. We will give protamine. We need to have a lower ACT to put the manta. Can you push on so take it? Not going easily, huh? No, okay. Okay, try to go on this. It's an échange, hein? Okay, let's put a 4 or 5 French catheter. Ah, are you going, man? No, not going easily. Okay, we have a good. Pas ma mère, DAV peut-être. DAV. 4 French catheter to go on the left side. Ouais. Non, on va donner la protamine. Let's give the protamine now. Maybe for 40, maybe 40 milligram of protamine. So this is now a 4 French catheter to try to go on the other side. On a-tu un guide stiff d'échange? Après ça, on va prendre un stiff d'échange. Here we are. Okay, let's stay here. Let's put the stiff guide wire. Après ça, je pense que je vais prendre un multi si on avait un multi sur la table. So I'll put a stiff guide wire now to go back with a catheter ready to inject after the manta. Can you show now the heart rate, please? The MACLAM. Thank you. Okay, now, okay. See, patient is in AFib. The QRS, I think it's a bit larger. Can we confirm that the QRS is a bit larger than the beginning? There's no sign of complete AV block. On a-tu un multi? Parfait. Oui, multi s'en vient. This French. And now multi-purpose catheter, 6 French. Puis avant. So QRS at the beginning was 88 millisecond, and now it's 120. So a slight increase, but not too bad. Okay, let's do now the manta. So yeah, we will show you how we do that here. Est-ce qu'on pourrait mettre peut-être on pourrait peut-être se mettre un peu de serviette? Ah, c'est bon, non, vas-y. We have a stiff wire in place. This is what we have used at the beginning of the procedure to measure the depth of the artery. The depth of the artery, I think, was 4 centimeter. So now we will introduce first part of the manta up to the end. It's the catheter to deliver the plug. This is insert on the stiff wire. This is an 18 French device. Do you see that here? Can we show the plug? Here, okay. This is the plug that we will introduce. The plug is here. We insert that directly on the guide wire. Plug now is introduced in the introducer. There's 2 click typically. Okay. So we just gave the protamine, so we should be fine in terms of ACT, not too high. This is what we want in using this closure device. And now, yeah, Ahmad will come back until it reached the mark of 4 centimeters. 5, we said? 4. Can you confirm that it's 4? 4 centimètres pour le menton? 4.5, 4.5. 4, okay. 4 centimeter, okay? This is, so the depth of the artery was 4 centimeter at the beginning of a case, so we need to go back with this to 4 centimeter. Okay, and now at the 4 centimeter mark, you will open the anchor in the artery that you will pull back against the wall. And now you need to pull back like this, push the collagen plug on the artery, so between the anchor and the vessel wall, on top of the vessel wall, sorry, of the artery. Often there's small residual bleeding coming essentially from the track. Not too bad here. So plug is down. We can remove the wire, do a gentle compression, and we will inject soon to confirm there's no significant bleeding of the artery. There's some bleeding. We can press some. I think it's bleeding. Okay, press a bit. It's still bleeding, maybe too much. We can potentially, we can always press gently on both sides of the plug. The problem here is the fact that the pressure is quite high. She's giving some nitro. It's 140 now, so going down with nitro. And as soon as it's not bleeding too much, we will inject to confirm the hemostasis. Patient is stable, no tachycardia. The conduction disturbance is stable also. The QRS is still enlarged, but not too much. Okay. It seems not bleeding anymore, so I think it's a good timing to start to look. We were, can you open that up below? Oh, okay. Let's do an injection here. Should see. Okay. So injection. So no bleeding at all. There's no stenosis. You see the plug on the artery. You see a small dot here on the artery. It's reflecting the plug. So perfect. Yes. So we will finish this case by an angioceal maybe on the left side. There's nothing more to do on the right side. Is there any more? Do we have more time? Is it finished? Is there any more question coming from the audience? The last thing to discuss sometimes is how we should treat a patient after valve-in-valve implantation. Should we anticoagulate? The question is easy to answer in this case. Patients in AFib, we require anticoagulation. But we like typically in the first 3 months of invasive procedure like this, we like to give dabigatran because there's a antidote available widely in all hospitals. So it's probably better to have a drug that you can reverse in the first few months after the procedure. If the patient is eventually coming with a complication in relation with this. So this is typically what we are going to do, switch the blood thinner patient that he's taking right now for dabigatran for 3 months. You can always also discuss should we have and should we add an antiplatelet agent. I think it's a case by case, potentially depending also on the bleeding profile of the patient. It's a large valve here. I would probably not recommend to give an antiplatelet agent on top of the anticoagulant. So angioceal 6 French for the left femoral artery. So I should say that a patient came in this morning. He will be able to walk soon following this procedure. Maybe in 2 hours, he will be able to walk. And tomorrow he will have an echo and will be able to go back home next day. Because now we are quite late today, but if this is a patient that potentially eventually can go back home same day. But I think it's pushing a bit. So definitely tomorrow we will go back home after his echo. So final suture in the right groin just to prevent the bleeding coming from the track. But there's nothing significant at this level. And this is it. All right. Any more final thoughts on this case, guys? I think it's amazing result. We cannot expect more. Final gradient of 2. I'm sure that tomorrow on echo it will be probably less than 10 millimeter of mercury. It's always higher on echo, as we all know. It's a pressure recovery phenomenon. It's why invasive gradient are always better than echo gradient. But I think the final end gradient for this patient is definitely 2. Again, record invasively. So no matter what the echo gradient tomorrow, I think this is the one that we want to to keep in mind. So I think we will stop at this point. Thank you again for your visit in room 2 at Montreal RTT2 today. Looking forward to do more case for MedStream soon. Il faut-tu